Good day and welcome to this session of the SAMED 2021 Annual Conference, Growing MedTech Post-Pandemic, Adaptability, Resilience and Sustainability. I'm Sarah Cohen, the SOLDA Executive Officer, and I'll be facilitating the session on COVID-19 testing, lessons learned for future pandemics and outbreaks. We look forward to the session and we request that our delegates make use of the chat or the Q&A facilities to ask any questions of the speaker. COVID testing played a vital part in the response to the pandemic. The IVD industry rapidly adapted to the needs of the situation and enabled resource management through molecular, antigen, and antibody testing. In this session, we take a look at what we learned in terms of the various types of testing and testing models as we prepare for future health emergencies and crises. Sharing her insights with us today is Professor Lesley Scott, the Associate Professor at the Department of Molecular Medicine and Haematology at Wits University. Professor Scott is an Associate Professor and Head of Research and Development in the Department of Molecular Medicine and Haematology, and I lead, which is the Innovation in Laboratory Engineered Accelerated Diagnostics in the School of Pathology, Faculty of Health Science at the University of the Witwatersrand, Johannesburg in South Africa. Lesley has a PhD in molecular medicine with more than 25 years of experience in accelerating innovative HIV and TB diagnostic and quality programs from concept to implementation, followed by continuous quality monitoring. In April 2020, Lesley and her team applied their evaluation protocols to COVID-19 testing to assist in recommendations for medical device regulation. I welcome Professor Scott and we look forward to your presentation.
Thanks very much, Sarah. Thanks for that introduction and hello to everybody. And really thanks for the opportunity to share some of our insights. And I really bring this to you from quite a big team. So I hope that I can cover all the aspects of the team members. I'm just going to share my screen. Please tell me if you can.
Yes, thank you. We see your screen. Thank you so much. Yes.
Okay, great. Thanks. Right, so I think we really have learned quite a few lessons. And I think what COVID has taught us is really about future preparedness for pandemics, but also the role of diagnostics and how important they are, and not to lose the traction that we have gained through COVID response, but also to continue this for HIV, TB, and other diseases. So I just wanted to give you a quick update, and I'm sure you're all aware of this on a constant daily or weekly basis of the information of COVID in South Africa, but it really is a reality check. And you can see from the Johns Hopkins website, you know, the real numbers of the number of cases that we have, the number of deaths that have occurred, the total cases, and really the impact that it has had in South Africa and globally. On the right, I think it's quite important to be able to see the details of what occurred in South Africa from the early on. And if I can just identify for you the breakdown of this graph, which really comes from the NHLS data. This is not reflecting the contribution of testing from the private sector. I will only be representing what we see from the NHLS public sector testing, which to date is more than 6.5 million tests. And really, thanks to a big group of the Virology Expert Committee, the National Priority Program of the NHLS, to be able to provide this kind of updated information in real time. So here you can see the total number of tests being performed in green and those that are reported as positive for COVID, and then some unsuccessful or inconclusive results. And just to highlight the total positivity rate, you can see is the main red bar. So it's not unfamiliar to all of us of the first, second, and third wave, and actually the differences across some of the waves in the positivity rate and also the extent of the waves. So this is really just a reality check for us to see how COVID did impact us, but also the response of diagnostics to be able to test, and specifically the changes across the lockdown levels. So what specifically about diagnostics in South Africa then and now? I kind of put this in three bins, and we can really see early on there was really unpreparedness. We didn't know which test to use. We didn't know when to use the test. There were supply chain limitations. We didn't have enough swabs. We didn't have the preservation material or transport media. PCR tests, I'll go into a little bit more detail in how current footprints of diagnostics were leveraged. The cyclical nature of COVID also brought with it some challenges on the testing demands. Then as we gained more experience, we also wanted to see, the performance of tests. What is a good test? The alternative specimens. Can we use nasal versus nasopharyngeal? Can we use saliva? Can we even use sputum? What about co-testing amongst our TB and co-infected HIV and COVID patients? What about multiplex testing? And of course, really important questions we started asking now is post-market surveillance. What can big data in real time tell us? And what's the value of the cycle threshold? And I think more recently now we are starting to ask questions around diagnostics, how they should adapt. What is the impact of variants? What is the changing landscape now with vaccines? And of course, throughout the entire COVID era, the rapid response through to the digital health information. So I'll try and cover a bit of these, and happy to take some questions later. So just a quick overview of the diagnostic focus when we say specifically on the target. And for the different diagnostics, and I don't have to share this really with this group, but we really always look at two aspects, the virus and the host. And from the viral perspective, there's the genomic RNA, the nucleocapsid, the membrane protein, envelope protein, and the spike glycoprotein. Within the viral components is the RNA and the proteins, and these are then separately used in diagnostics, as you are all aware. The antigen detection tests, which could either be ELISA or lateral flow immunoassay tests, PCR tests that really target the RNA, and this is quite important because it's an RNA virus that has to then be transcribed to DNA. So different types of PCR assays have been developed, whether they include isothermal amplification or even the most recent use of CRISPR technology. And then, of course, antibodies from the humoral response to the virus. Again, different types of antibody detection assays, and really what has been extremely useful, specifically in the vaccine world, is serum virus neutralization assays. So really, if you think about the diagnostics within the COVID response, has really covered areas across both detecting the virus and the response to infection. But which test do we use? And the question we always are asked is, when do we use the tests? I thought this was quite a really good review, systematic review, which I think covers everything and has put all our concerns into one diagram. If we really look at the breakdown of what happens before symptom onset versus those that are after, follow the blue line. This is how the viral concentration increases over time. So you'll know the diagnostic window for the PCR test is really in this area. And it's quite critical to identify where a potential negative can occur or a potential false positive. If you have a look at the immunological response, IgG and IgM occurring first, and increased sensitivity across time, which is also critical. When would you use the correct kind of serological test, and early on a PCR test? So I think this took a while for scientists to better understand, and we really have a good handle on this now. And I think within the South African environment, it also took us time based on the availability of tests and the regulatory process. So if you look at the diagnostic landscape within South Africa, and here, as I mentioned, I'll only focus on the NHLS testing platform. We know that based on the HIV viral load program, as well as the molecular TB program, we really have a huge footprint for molecular testing. In the HIV viral load, we have capacity for more than 6 million tests per annum. GeneXpert, more than 2.5 million tests per annum. So this platform was really on target, on track for all diagnostic needs for our HIV patients. So this could have been leveraged for COVID, say molecular tests, but due to supply limitations and really trickle from the north, as we'd like to say, the capacity could not be capitalized completely, which meant that we had to be able to leverage additional academic platforms, additional research platforms, and really rapidly validate assays that can then be added to the footprint. And over what we see now, and again, courtesy from the NHLS and the National Priority Program, is the top assays that are being used are the CGene assay, which is really an open platform, GeneXpert, which is a closed platform and more distributed in a more district decentralized fashion. TACPath, which is mostly used on high-end research and academic and virology platforms. And again, Roche Cobus, which is utilized also for code testing for the HIV, and several others. But what it did show is the rapid need for validations and being able to provide testing on these existing platforms. So this required rapid innovation, and I have to say this really was brought about through partnerships and collaborations, and being able to leverage existing networks, either the HIV or the TB networks. We had to rapidly modify our work streams. We had to rapidly develop materials for reference testing. And this was done with various partners within the manufacturing environment, within the academic environments, and within the virology groups. Viral cultures were rapidly manufactured and continue to be manufactured with partners such as Professor Wolfgang Preiser and Professor Bhavesh Khanna. We rapidly developed a biorepository to be able to capture and collect samples, because the waves were cyclical and we couldn't wait for the waves to occur to be able to validate new assays. Digital tools were repurposed, and you can see the eLabs tool, which has been well utilized and implemented in several countries in Africa and South Africa for viral load testing, had to be rapidly repurposed for COVID, as well as now for TB and ERD and other assays. We had to rapidly divert funds. And again, this was through partnerships, groups like the CDC, Global Fund, Bill and Melinda Gates Foundation, were able to rapidly allow us to use our funding to be able to develop assays, protocols, and evaluation systems. Clinical trials had to be rapidly initiated, and this really required ethics to become alive, regulatory bodies to come on board. And I have to say, within an emergency environment, there was great collaboration, which now still continues. We also had to learn how to do webinars and train remotely, which now has actually continued to be used as a really good platform. And of course, data skills had to be enhanced. and had to be reused for not just HIV and TB diagnostics, but for COVID. But in all of this, there are complexities across the diagnostic and the pathology value chain. But these gaps actually identified can be areas of great innovation. And you can see typically what we speak of the value chain, the patient, the specimen, transporting that specimen to the central testing lab and getting the result back through a system-wide connectivity. I've just highlighted some of the areas where we really showed complexities, so in relation to what it could mean to a diagnostic. The stage of the infection, I've already shared that with you. A diagnostic can perform differently based on the stage of the infection. Infection control practices may impact on diagnostics in inability to really obtain a really good specimen. Healthcare worker variability we've seen in specimen collection. Point of care testing can provide variability, as do centralized labs. Finger stick versus phlebotomy, these are all variables and complexities that can impact on a diagnostics result. Do we look at self-collected, nasal versus nasopharyngeal versus oropharyngeal specimens? And of course, diagnostic algorithms really impact on how the patient is identified, linked to care, and the diagnostic that's required. And these are different use case models. On the specimen side, we really saw this with COVID, the different types of collection methods, the quality and the stability of the specimen, even down to the swab type. You know, one swab is not the same as another, and I'll share that with you. Even the shaft type can impact on a diagnostic. This we've really seen as important. The UVT, the PBS, the UTM or the saline, these buffered solutions really do impact on diagnostics. The alternative specimens, saliva, sputum, these are all that need to be validated. And of course, can we use this for code testing? And can we store these specimens? Are they able to be used later after storage? Transport impacts on specimen stability. And in the early days, we had no access to PBS or UTM to be able to be dispensed at site. So we had to transport swabs dry. Did this impact on diagnostics? At the central lab, there's really huge potential. The different platforms, open versus closed, which will require front-end extractions. And this in itself is a dilemma and can cause bottlenecks, especially during the high testing and peak times of waves. Processing workflows need to differ. PCRs themselves are all different. Gene targets are different. Some have single, some have dual. Cycle threshold range is different. Limit of detection is different. One cannot be compared directly to another. And of course, all in result interpretation. This too becomes subjective or based on different types of software or different threshold settings. And of course, surveillance and sequencing also brings with its variability. From a system-wide connectivity, the result capture and connection to the laboratory information system is critical. Linkage to care is critical, and of course, and I'll show you later on, continuous quality monitoring, as well as digital health transformations. So these are all areas, either gaps or areas that increase the complexities for interpreting diagnostics in our settings, as well as definite areas for innovation. So what is a good test? And for this, we really had to look at performance evaluation, specifically and still under emergency approval conditions. I've just highlighted for COVID the 3 test types, molecular, serology, and antigen. And for this, the evaluation protocols had to be developed each individually. Viral cultures were used, reference materials were provided or sought or brought in from outside commercial groups. Residual clinical specimens, we had to really look at those in different viral load concentrations and ensure that we evaluated across the spectrum of what a patient would be presenting with. and of course controls, which were limited early on. Serology required clinical trials to be able to access patients post-infection at various stages. And this in itself brought various dilemmas on the statistical side, the evaluation side, interpretation, and the role of the different types of serology, formal versus RDTs. Not easy processes to implement, and especially within large programs. And then on the antigen side, which came later, is really the inability to be able to do large-scale clinical trials on every single antigen that required evaluation. So laboratory protocols had to be adapted. Again, recombinant proteins were provided through local networks and developers to be able to use as reference materials. And again, a lot of R&D had to go into being able to use these residual specimens to be able to adapt the right kind of protocol. So these really brought with them, again, challenges. How do we make panels with different volumes of specimens and residual volumes? How much is left? How much can be used for evaluations? Reference materials had to really target the right kind of assays. Some assays could not be detected using various reference materials. And of course, more recently, the impact of variants. Are variants needing to be differently detected? What impact do the variants have on the current molecular diagnostics? For serology and for antigens and for the molecular evaluations, what's the right sample size to do in a rapid emergency approval evaluation? Do we collect specimens from patients admitted in hospitals or those from community screening? And do we collect specimens from different age groups? We've seen that with COVID, that various age groups have different concentrations of virus. Patients admitted to hospital are ill and have higher viral load concentrations than those seen in community screen and test. And of course, all of this had to be looked at in cost and time constraints, as well as the cyclical nature of COVID infection. We could only collect specimens during the waves, but evaluations were required throughout the time period. So these are just the challenges. And of course, it's not just on the front end, it's also on the acceptance criteria. When evaluations of diagnostics were rapidly needed early in April last year, there were no guidelines, there were no international standards, there was no WHO protocols. They only became available at the end of August 2020. So in the interim, teams of scientists and evaluators and HTA specialists had to get together to determine the right kind of evaluation protocols and set acceptance criteria. We had to work out the right gold standards. We had to ensure that specimens were collected from local populations that were relevant for use and uptake in South Africa. So here you can see the evaluation pipeline that was put in place in April 2020 and continues. The PCR assays, and the large number of landscape reviews that had to be performed and continue. And it's really incredible to see the amount of diagnostics that have been developed. But sadly, few come out the bottom. And these are through processes of rigorous evaluation and still ongoing. So if we look a little bit more detail at serology diagnostics, I urge you to review the local paper from Anura David in our group, which really showed the lateral flow assays. Kit sensitivity had huge ranges, 8 to 100%. Kits produced invalid results. This was great variability. You look at the operational characteristics, which was also needed to be part of the evaluation protocols. There were differences noted in the type of cartridges used, the amount of specimen required, and the test duration. Cassettes and the cassettes of the majority of the kits evaluated detected both IgG and IgM, but many kits evaluated didn't contain all the consumables required for point-of-care testing. So the leap to be able to implement it in the field was tricky. And, you know, even down to the droppers not being provided in kits, these are really difficulties that implementers will face and really evaluators and regulators need to review. On the antigen diagnostic side, several kits, you can see the different types, chromatographic, those that came with analyzers, those that were standalone, those that even required UV torches. This, I have to say, was one of the most challenging evaluation processes to undertake. And you can follow through the various changes that had to be made to be able to remain relevant, to be able to continue performing these evaluations, to be able to provide developers and suppliers with good information, based again on laboratory evaluation, not clinical evaluation. So here we ensured that panels were used across diagnostic tests. We made sure categories of high viral load, medium viral load, and not in low viral load, because the threshold for antigens are really less than 30, and this is the WHO standard. So we were able to put these assays next to each other using panels that were consistent across the protocols and able to see those that were performed well, positives with red, negatives were green. Some assays you could see had false positivity, even though they looked really sensitive. So all these processes had to be developed. The evaluation process evolved, and of course this was done in collaboration with the NHLS as well as in-country regulator. I mentioned earlier, swab's not a swab is a swab, and this is really not even reviewed from a regulator's perspective. Neither are the UVT processes. So all of these bring with them complexities and challenges when evaluating diagnostics. Here we could see of the molecular assays that were recommended, the majority of them really included the N gene target. And this is quite critical. And we see more than one target really performing well. And there are some assays that had good sensitivity, but poorer specificity. So, you know, really a lot of work has gone into being able to evaluate these technologies. We also, being able to use a single laboratory information system through the NHLS, the central data warehouse, and the ability to obtain the cycle threshold values from each PCR, we were able to combine the N gene targets from these three top assays, and inferring the cycle threshold as a marker for viral concentration, we were able to do wave prediction. We were able to look at the concentrations of virus by age group, by location, and this has really become a good marker to help inform the epidemiologists, as well as indicators for where do we place technologies. If the limit of detection for antigen assays is below a cycle threshold of 30, why would we use it when viral concentrations are low and testing is low? But why not use it more rapidly early on to reduce the testing demands on labs? Use these more in the field to be able to detect a rapid infection at point of care. So all of these processes have helped to monitor diagnostics as well as the program. And this is just an added area of using the cycle threshold and the gene targets centrally connected. We were able to monitor the TACPAT's S gene target failure and see the alpha variant distribution and circulation through the population. So these were specimens received that we would be able to identify the S gene target failure. And again, the Delta variant, we could see based on the all-plex reduction in hybridization of at the RDRP gene region, really the increased circulation based on targets for continuous quality monitoring. And these are areas that we continue to monitor with the virology groups. So variants, as I mentioned before, really will impact on diagnostics. The variants of concern, the variants of interest, and I'm sure you are all well up to date with this, which are circulating in which populations and during which waves, but really how diagnostics need to remain relevant and updated. And there's huge support internationally to be able to ensure developers have access to variant cultures, variant specimens, to be able to test their diagnostics. And we are continuing to do that here too. We also are looking at performance evaluation of the variant assays, as well as new sequencing technologies. Again, this will require specimens to be isolated, identified, assays to be lined next to each other, head-to-head comparisons, and not just on the typing assays, but also on NGS platforms, how we can really assist other African partners to be able to leverage the current NGS programs that have been initiated in the networks that appear to be really strong in South Africa. But we will need industry partners, we will need their platforms, we will need to be trained with full bioinformatics support, and of course funding is critical. And this is an area for the diagnostics industry to really participate, as well as link to the NGS networks for alerts. So don't forget that all of the hard work that we've done on ensuring diagnostics are validated, regulated, implemented, we really need to start again. With the great rollout of the vaccines, and we really do need to urge that the jab is worth the pain, but diagnostics need to adapt. And we need to ask these questions, and you can see I haven't put any answers on here because I think this really needs to be addressed in a larger forum. Do we use serology assays? Do we be able to take the ability that we can identify N versus S proteins? That can give us an idea of those that are naturally infected versus those that have had vaccines. Do we really ramp up the sensitivity of PCR assays? Or do we use antigens more frequently? And do we push that to self-testing and self-collection? Or do we even do self-collection and tag that to ultra-high throughput testing, which are platforms that are now becoming available through industry partners? So these are all critical questions to ask, but not to leave out the digital diagnostics and the fact that we are really moving towards patient-centric approaches. I've just given, and courtesy to Lindsay Isherwood from our digital health team, a brief overview of the areas that we are investigating and really have been used for COVID response and others. We want self-registration, self-sampling, self-testing. We want to ensure that the results are returned. And here you can see really the impact that the eLabs program has had. The correct health messaging, self-monitoring. We even want to look at wearables. Biometrics, do they still have a place for us to use as unique identifiers and link results? And of course, all the way to RDT readers. Can we capture all those rapid strip results and ensure that they are kept within the connected diagnostics? The results are maintained within the warehouses. So there really is a huge development innovation area in digital health and areas that need to be expanded. So really, in ending, the COVID-19 has really shown the acceleration for diagnostics, but we need an alliance to support the global health diagnostic initiatives. And I urge you all to look at the comments that have come from Nature and also Lancet. There's a 5-priority framework that has been identified. We need to create a diagnostic agenda, build diagnostic literacy, generate the roadmaps for effective diagnostic systems, diversify manufacture, and this really has to be stressed for South Africa, and expand beyond the health sector. And you can see the priority areas, and you can also see the support through the ACT process and accelerator, as well as initiatives within LMIC through AFCAD. And one of the initiatives really stressed by AFCAD is to promote local manufacture and improve independent access. And this is really what we've seen with COVID. So in final, the lessons learned and future preparedness. I can't stress more that we cannot spot a potential outbreak without a diagnostic, but that the lack of ease of access makes diagnostics the weakest link in the care cascade. COVID has shown us that point of care is really critical. Patients really want to take charge of their own health path. Is there a place for self-collection testing or ultra-high throughput testing? Innovations are needed across the diagnostic value chain. We really need local manufacture for good quality diagnostics. We really need to ensure that digital health drives the diagnostic agenda, but scale is everything. It's everything from development through support, through implementation. And through those partnerships are key, and the right partners. And of course, continue the post-market surveillance. So I think what we also need to do is keep the attention, use the visibility that diagnostics gain for COVID and translate into a sustainable action now. Media, the public apps, I think they should continue. I think we should use them more for HIV and TB. These programs have really been hampered by COVID and during lockdown. Diagnostics speak should be simple and show the important links to epidemiology, surveillance, and preparedness. We need to continue strengthening the effective diagnostic systems, and this is really collaborations through academia, regulators, innovators, industry partners, and implementers. And the regulatory environment is maturing, but does need some balance. So it just remains for me to thank a really very big team. And I'm not going to go through all of them, but really large support and from funders and innovators. And thank you for listening. So I'll hand back to you, Sarah.
Thank you so much, Prof. Scott, for an excellent whirlwind tour through all the hard work you and your teams have done during the COVID pandemic. And I think the broader population really appreciates that, taking us through the preparedness, the test performance, and the adaptation and innovation that has taken place has been really interesting and exciting today. We do have a number of questions. So someone here, Miss Amanda Wild, has said, great session, Prof. Scott. Wound swabs are typically taken after thorough washing of the wound surface. Otherwise, we are more likely to pick up contaminants. Are we, on reflection, confident that nasal swabs were the most appropriate diagnostic for SARS-CoV-2? And is it possible that asymptomatic positive swab cases could have perhaps been contaminated rather than infected with the virus? So handing back to you, Prof. Scott.
Yeah, thanks. I mean, this has been one of the biggest questions we've grappled with as well. So early on, and still from where we are now, nasopharyngeal specimens are really, the best. Oropharyngeal as well. Nasal, however, there have been a lot of studies to show that nasal is as equivalent to nasopharyngeal or oropharyngeal. I think what studies that we have done in clinical settings have shown is really to take the correct specimen. You can take a poor nasopharyngeal specimen with the incorrect swab, yet it's nasopharyngeal. compared to a really good nasally collected specimen with the right kind of nasal swab. So I think, you know, there really needs to be good training, good information as to how to collect the right specimen and also what kind of swab to use. We've seen that, you know, cotton is not good. Polyester is better. And so I think these are important aspects. And the other thing that we've also noticed is to be able to support healthcare workers and patients to collect the right kind of swab. There've been quite good use of digital health systems to be able to show patients how to collect the correct specimen, and how to ensure that you keep the swab in your nose for 15 seconds and you swab both nostrils. You know, these are things that are often not always translated and can impact on the type of specimen collected.
Thank you for
I'm not sure, well, did I answer all of those pieces, or in relation to false positives? I mean, that's a tricky one.
It is quite tricky, yes, it is. Difficult to say. Perhaps I can ask you what your thoughts are about saliva for testing. Would there be a place for that? Any experience that you could discuss?
So that, you know, that really, you know, I think past nasal swabs, saliva has really become quite key for us. Again, there have been quite a few studies in the literature have shown there are some inhibitory substances in saliva. There are also difficulties in extraction with saliva. It's easy to do, but again, the quality is not always ideal. And a little concern, which I think, you know, really needs to be discussion with industry and regulators, is there are some PCR tests that in the instructions for use, they say saliva can be done. Those haven't actually been well validated and not well validated in clinical settings to be able to inform. One of the concerns is really in the vaccine environment. You know, do people say, oh, I don't really want the vaccine, I don't want the jab, I don't want the pain, but let me rather do routine, continual and frequent testing. And so sputum is really, or saliva is really good for that. That's really the questions being asked of the vaccine world. But the sensitivity of a vaccinated candidate, you know, of the amount of virus could potentially go down. In saliva, it could go down even less. So these are not opt-out for the need to vaccinate. So I think these are questions that need to be answered now in the realm of variants and vaccines. And saliva hasn't been completely answered.
Right. Thank you for that, Prof. Scott. There's another question here from Simone. What is your position on the place of sampling? Is a tent on the side of the road suitable? Should the distributors monitor where and how the point of care tests are used? I know this is a controversial question, but what are your thoughts on this?
So I think point of care needs to be part of the diagnostic value chain, all the way up to centralized testing. But quality monitoring is key. And the way to do that is to have a connected diagnostic. So I would be very keen to look at point of care tests that have connectivity solutions, that are able to be centrally monitored, that have quality monitoring processes that are ongoing. And I think those are key to any point of care test, whether it's on the side of the road, in a tent, in a hospital, at casualty, in emergency, or in other decentralized settings. I cannot stress the importance of connectivity and quality monitoring. And I think COVID has shown us that point of care and rapid testing is really needed.
Thanks, Prof. Scott. And there's another question from Dr. Sandile Melongo. What was the impact of substandard test kits and what can be done in future to prevent that from happening?
So impact of substandard tests, I'm not quite sure I fully understand, because they would all have to be validated, all have to pass a certain acceptance criteria. So potentially, if you look at how many went in the funnel at the top and how many came out, sure, there were substandard tests, or those of poorer quality, or those that did not have the right suitability for the current platforms. There's some really good tests out there, but they weren't adaptable to the current footprint being used, both private and public labs. So I think one has to really look at qualifying that question a bit further.
Thank you. And then from the chat, thank you, Prof. Scott, very informative session. Has the national testing for COVID captured all rapid testings done by HCPs? And do you see rapid testing becoming the mainstream in the future?
So that is also a tricky question. The antigen test results need to be captured. There are processes to be able to do that through the NHLS and the NICD. And also through private. So yes, they should be collected, they should be connected, and they should be reported. The extent of that is hard to say. On the molecular side, we can monitor the number of tests that are being done, and you can see as the wave goes down, the number of tests go down. So is that because antigen tests have taken the place? I doubt that. I think the two are used together, and it's hard to be able to tease that out when the wave increases or decreases. But again, it comes to the previous question about connecting one's results to be able to look for both monitoring and on the diagnostic as well as on the program.
Thank you so much. I'd just like to raise one more question, and I did raise it in a previous session today with the regulator. I think there was agreement on the potential for self-testing in the future. How do you see that being controlled and regulated? Because the regulator said they would still be discussing the potential for self-testing in the country in an earlier session, but what are your thoughts about that?
So it does need to be discussed, because I think it is going to be an aspect that will need to be addressed, and to also assist the in-country regulator. They're not alone. WHO is trying to discuss this as well, and one of the biggest aspects around self-testing is really going to again be around quality. The questions are going to be more on what is the support provided to the person for being able to test correctly and to be able to follow up on the results. I think the question is going to, from a regulator perspective, going to be more on what is the support provided for a self-tester sooner than what is the performance of the test. So I really look forward to this next phase, because I don't think it can be ignored, but I think there is a framework that needs to be put in place. And the local regulators are not alone. This has not been well defined globally. Although in saying that, there are already self-testing. You can do it with your own iPhone for monitoring blood pressure, your glucose. All of these have already been used. But for infectious diseases, it's going to really require a different agenda and a different framework.
Thanks so much, Prof. Scott, for a really valuable session with you. I don't see any further questions, so we would ask that our attendees take a moment to complete the session. And while they do that, I'd like to thank you. We appreciate the insights and information shared with us today. We appreciate your time, and we look forward to future engagement between SAMED, SALDA, and yourself. And this concludes day 2 of the SAMED 2021 annual conference. Tomorrow will be the third and final day of the conference, with sessions around localization, market access, and the national health insurance. We look forward to welcoming all our delegates back tomorrow. Thank you so much. And thanks, Prof. Scott. Have a good day further, and to all the delegates.
Thank you.